Not an easy topic. All the topics today are not easy topics. Our next presenter is Eric Simpson, who will talk about atopic dermatitis patients with new onset dermatitis on the face, something that we've always seen in our practice with atopic dermatitis patients, but we tend to see a little bit more with the advent of some of our new treatments.
All right, thank you so much for having me, Robert and others. It's a real pleasure to be here. I agree, it's kind of a niche topic. I had to put something new together here, but it is very clinically relevant, and I see it every day. So I have a case from just like last week. I don't know what caused it, so I might not be the right person to be talking about this subject, but I'll just kind of give you some general guiding principles and whatnot to think about with new-onset new-onset facial dermatitis. Okay, I do a lot of trials and consulting for companies. Stop whining about the rain. This is Oregon. This is like beach time in Oregon, so it's not that bad, okay? Seriously. All right, so I'll talk about general approach. And then I didn't know how to categorize things necessarily, and I wish I would have seen Peter Leo's review of this topic before yesterday, and I could have maybe come up with something, but I kind of categorize things by pathophysiology, really. Okay, so this is the patient I saw last week. I don't remember, I didn't document it well, but no eczema on the face, that's what she said. Before, this was a dupilumab, patient on dupilumab. And so she came in with this new facial rash, so very clinically relevant. I thought it was kind of interesting. I mean, I always see this philtrum, however you say this, above the lip. That's common atopic dermatitis. I see that all the time. And so I thought this is for sure just refractory AD. And then a little bit of angular cheilitis. So, you just have to kind of use your normal derm training. Where is it? When did it start? Were you using topical steroids before? Are you using them now? What's your normal care routine every morning, every night? What are you putting on your face, et cetera, et cetera, et cetera. So you just approach it like a new rash. It's, relatively simple. Again, I don't know what caused this. What are the symptoms? Does it itch? Does it burn? The burning is more like Jonathan would say, maybe irritant, maybe topical steroid withdrawal with more burning than itching potentially. And then morphology. If I see one pustule with my dermatoscope, then I'm good. I know I'm in the rosacea form type category. It's pretty easy, doxy, treat like rosacea, too much steroids, etc. If it's flat and red, it could be just about anything really. But topical steroid withdrawal starts coming into play, sharply demarcated. I'll show you pictures of that. Scale, I don't know, it seems like a lot of the pictures where ketoconazole works, they're all rural scaly, like a sebderm type of effect. Think about distribution, previous therapies, etc. So I said for her, so I haven't had a lot of success with ketoconazole or itraconazole or fluconazole in treating head and neck atopic dermatitis. But I was like, okay, this one I'll do. I'll try it. It's been reported to help with facial dermatitis with dupilumab. So she called and said it's clear, but I didn't take the fluconazole, I used topical steroid. So I still don't know what she has exactly, but it was steroid responsive, could be topical steroid withdrawal potentially, but the history was not positive for that. So then Dr. Leo nicely summarized what I just said in a recent review, so I highly recommend everyone look at this review of kind of head and neck dermatitis and morphology distribution for atopic dermatitis, but I don't know, I kind of categorize, let's see, can you see my, yeah. So here's the differential from his paper. Allergic contact dermatitis, heard a lot about that, we'll hear more. Rosacea, steroid-induced rosacea, perioral dermatitis, demodiciosis. I kind of put those three things together really. I don't know if those are three different diagnoses, I treat them exactly the same. Topical steroid withdrawal, so thank you for putting that in there. Malassezia head and neck dermatitis. I'm not a huge believer in this, but there's studies and we can argue about this. Let's look at data and everything. But it is an intriguing concept that hypersensitivity malassezia may cause facial dermatitis. And then last over here, dupilumab associated facial dermatitis. So we'll talk about that as well. So let's start with drug-induced. What is this? What drug is this? Dermatitis, no. Topical steroids, right? So perioral, periocular dermatitis, even in kids, too much topical steroid on the face causes this rosacea-like syndrome, peri-orificial dermatitis. It's, I don't know, I don't really call it a dermatitis actually, it's more of a rosacea type infiltrate. So I don't include that in my eczematous differential necessarily. Okay, what's this drug? Same thing, topical steroids. So the patient on your left was clobetasol on the face for a year. She stopped it, and it was like she wasn't even putting it on her neck, and it just blew her up. And so she never trusted any dermatologist again. This will be a common theme coming up here soon. Rightly so. Like if she didn't either hear, like, don't do that, or whatever. It's just like, these people who are getting topical steroid withdrawal are upset, right? Because something we prescribed them is causing this horrific result. And she dealt with this for a year and was not willing to put on another topical steroid to kind of titrate down because they're extremely upset and scared. Same thing on the patient on your right. So, some of the keys are the history, of course, and if you say, please stop your topical steroid and tell me what happens, then you get this kind of rebound erythema and edema, and that kind of sharp demarcation on the right is pretty typical for topical steroid withdrawal in the head and neck. So the NEA came to us, the National Eczema Association, several years ago and just said, can you just look into this? We're getting a lot of reports of patients who feel like their eczema is topical steroid withdrawal, so we just did a systematic review. That's the only thing I know how to do when I have a question of, like, does something exist or not? And so we looked and we found 1,000 cases in the literature. And it turns out if you look at all the commonalities and you put it together in a kind of a descriptive way, most patients were using a mid to high potency topical steroid for at least a year. And most of the occurrences in the literature are on the face. I think it can happen pretty much anywhere, but I think the face is very prone to it, and patients with atopic dermatitis are extremely prone to this. I have no idea, and the questions out there are, how strong of a topical steroid do you have to use? Does everyone respond the same? How long do you have to use it before you start getting this side effect? These are not known out there, actually. We don't know the prevalence. We don't know how long to use topical steroids in the face or which type. So I really encourage all of us as a specialty to kind of do more research into this area and recognize it and try to understand this better for our patients. So it did look like there was kind of two morphologies. It was this erythematous type, that real sharp demarcation, this burning symptoms that they primarily had. It wasn't itch, it was burning. And then more of what you would expect with like a rosacea-like eruption that you would see with topical steroids, but it just gets a lot worse when you stop them. And it can even happen to adolescents. So this is what it looks like when you're going through withdrawal for like a year. So I still remember my first day seeing this patient. I said, what are you using in your face? We're talking about the rest of her body, and she said triamcinolone. I said, how long? Well, and I was just like, I'll talk about that like next time she comes in. And she left me a message saying, why did you ask me about triamcinolone on the face and how long I had been using it? It's like, oh, well, it's because this entity exists, blah, blah. So she stopped it and didn't use a topical steroid again, still hasn't used topical steroids. This was a year of like seeing her every other week of just shedding. And she'd come in with that on the right, that like shedding, crusting. It's like, that's staph. It's yellow, it's staph. Staph cultures are negative. It did culture one time staph positive, but it's just a very uncomfortable, horrific response to too much topical steroids. So just please recognize this. And it can happen to kids. So this is a kiddo we saw in the ED. Pustules everywhere. It looks like pustular psoriasis. It's like lakes of pus. But we asked her, what are you using in your face? Went through our historical questions. 2 years of triamcinolone on the face, like it was for mild eczema. But 2 years BID of triamcinolone would stop, and then would start getting the pustules. So got into that cycle. And so she cleared up, like we just had to do this steroid taper and some doxycycline. And then it can happen on patients on systemics. It can happen on patients on dupilumab. This happens to be a patient on a JAK1 inhibitor. Was completely clear, had never been clear before. But I started asking about, like, what are you using in your face, triamcinolone? do me a favor, just like stop it and then just send me a picture in a couple weeks. This is the photo that he sent on the portal, and he had this like very kind of, doopy red face look, but it's really just steroid withdrawal. He was on a JAK inhibitor. So now I think like everything is steroid withdrawal. So I may be over-calling it, but I want you guys to also kind of at least increase your sensitivity to at least asking the questions. So you can refer patients to the Topical Steroid Addiction Network. They have a lot of support services there. It's dangerous, because there's a lot of like doc hate on this site, as you might imagine. There's a lot of people who don't have topical steroid withdrawal. I had a patient who had been on the forums and Facebook that, I think half these people probably don't have topical steroid addiction, but it doesn't really matter. They do actually have a really great mission to identify it, to prevent it, to support people who have it all the way through. So I personally think it's worth sending your patients there, and they usually already know about it when they come to see you. So there's a couple champions in dermatology for topical steroid withdrawal. Maybe I'm becoming one of them, but it started with Dr. Rappaport. And he's a little controversial in my mind, but he at least raises awareness about it. And all your patients will know Dr. Rappaport. They've either talked to him personally, or they've seen his videos, or just somehow they all know about him. And then in Japan, there's Dr. Fukaya, another dermatologist. I wonder about sometimes when they're selling products for skin repair, like at the bottom of Dr. Fukaya's website, I wonder about what's the motivation behind it. But everyone in Japan knows about Dr. Fukaya as well, just so you know. And actually, Dr. Rappaport is important to start ITSN, the internet. But then they kind of broke. If you just want to like go down some rabbit holes, but just to know that it's controversial, and Dr. Rappaport's very upset at the AAD and the National Eczema Association and myself, and is upset just that I think because the underlying issue is that he feels like topical steroids cause all bad skin disease. And so I have a disagreement, a very respectful disagreement with him that severe eczema still exists, even in patients who've never had a topical steroid. But I think he would disagree. And there's a great kind of, for your patients who are going through this is great to have support and to see that there's hope in the end. So this is from the website. And then there's a YouTube video, very well produced. I think it's decently balanced. I mean, there's a little bit of, anti-Western medicine, but not bad, actually. And I think it really helps you. It's about 30 minutes. Helps you understand all angles. So I recommend watching it. I think it'll be helpful for you. And some really brave people who are going through it are on there saying what happened to them, how they went through it. My kid had it. I was told to put topical steroids on twice a day. You're not being adherent enough. Like, keep putting it on, next year. And then they go through this. So you can understand how upset some people could be. And so there's been some important statements about topical steroid withdrawal, that it exists, it's important, we have to address it as dermatologists from the National Eczema Society in UK. National Eczema Association has been extremely supportive and collaborating with ITSN, as well as the government at UK did this a statement as well, that it's real, it's important, we have to add it to the side effects of topical steroid. Okay, so it's a true side effect. Causes great suffering. Please recognize it. Prevention's best, so don't just keep refilling things. Try to use non-steroidals if you can for long-term treatment of the face. This sharp demarcation, this burning are all symptoms and signs that could suggest that. I don't know the treatment, but cyclosporin does seem to work. Dupilumab might work. TCS down titration, although a lot of people don't want to do that. Incorporate non-steroidals. You have to just work with your patients very carefully. Meet them where they are. Don't say it doesn't exist, or it's not, it's just mild hydrocortisone. It couldn't be. Just try to work within their framework, and I think you'll go far with them. Okay, what about this? Flushing on and off only when they're at the AAD. No. Alcohol-induced flushing from dupilumab. So I don't know if you guys have seen this. It's rare. I don't know what causes it. But it looks like that kind of aldehyde type flushing. I don't know. Patients I don't know how to stop it or prevent it. One patient was using tacrolimus ointment, the one patient that I reported, so that also might be a confounding factor. But there's other reports of no tacrolimus ointment, because I see it with just tacrolimus ointment. Okay, dupilumab facial redness. Had to add this to the package insert. It's not very clear, it's pretty vague, but I just think they're getting reports of facial dermatitis. And so this is a patient who complained of facial dermatitis from dupilumab. Every time I inject it, I get more red, more red. I'm just like, I don't know, I feel like you had eczema there before. So it's always vague, it's always hard to tell. He's better now, he hasn't changed his dupilumab. We just kind of treat him with tacrolimus ointment or other non-steroidals. So how often does this happen? How often is it really dupilumab? So this is really nice. This is Sebastian Barbaro's study. 1,000 people from France on dupilumab, and they saw that 4% had new head and neck worsening or new onset. About a couple months, 22 patients got better with just non-steroidal treatment. 2 out of 4 got better with antifungals. 4 patients discontinued. So it's rare, but it seems to happen. There's been other case reports, and the problem with the case reports, when you start reviewing these, just always think, did they consider topical steroid withdrawal? Because it sure looks like these cases right here look just like topical steroid withdrawal. And it turned out that 6 of these patients before dupilumab had burning symptoms on the face. 5 of them. Worsening of macular erythema was the sign. 2 out of 7 had symptoms, and they're all using topical steroids before and after. So I think it's confusing to say that this is only dupilumab induced, because I think there could be other confounding factors. It can happen in adolescence. It's always heterogeneous though. What's the morphology? On the left could be TCS withdrawal, but she was also using bacitracin intermittently, quote unquote, and was allergic to bacitracin on patch testing. So I think the literature out there is pretty messy. I think contact dermatitis, steroid withdrawal. So this is a paper, thank you for this, Dr. Drucker, meta-analysis looking at all these different cases, 16 different studies, 101 patients, 52 had a pre-existing facial dermatitis prior to dupilumab, and it's just heterogeneous, it's all over the place. So I don't have a final word of it looks like this, the prevalence is this, and you treat it like this. Because it's just crazy. It's just so I think when all of you start reporting more case reports, just please report a history of TCS use. Please report patch testing results. Please report morphology very carefully. Use photographs. Let me know if ketoconazole works or not. But we have a lot of work to do still. And so I tried to do this with my Korean colleagues. And we just took everyone on dupilumab who had a red face. Well, it turns out 85% of them had pre-existing red face before dupilumab. And the majority of them got better. So don't not use dupilumab or a biologic because you're worried that they're going to get more red face. So most of them are going to get better. And so there's just a couple categories where they had worsening. So they had red face and worsening. And here was they had no previous red face, but they were treating with topical steroids. So I think most of these patients, when we get to the bottom of this, is most of them are using lots of TCS. There's a small percentage of patients where they had this new onset AD. It looked like, new onset facial redness. It was macular red, but there was no consistent pattern. So sorry about that. And so this is a patient, red face on dupilumab. But he had a really bad red face before. And then he kind of had a moderate red face about 2 years in, and now he has no red face about 4 years in on dupilumab. So just try to treat through it, keep him going. Dupilumab, red face before dupilumab, no red face after. So 1 to 4% may be true dupilumab induced, but consider these other diagnoses that we talk about. Treat with non-steroidal or intermittent low potency TCS if you can. And then consider an oral antifungal. I just need better data for that. And then you could consider, if you truly think it's dupilumab, you could consider reducing frequency. 3 weeks, Q4 weeks. And we just need more studies. Okay, got 8 minutes. You won't see me. So when you go to Portland for the Montana Symposium in October for basic scientists and translational scientists, highly recommend it. Small meeting out in the middle of nowhere. Don't bring an umbrella. When you go to the SID, don't bring an umbrella in Portland this year. Okay, these are just some photos, really no studies. So just so you can identify them as clinicians. What is this? Yes, thank you. Eczema herpeticum. You can see the herpes labialis on the lip. Kept getting it. Even if you had erosions on the scalp, if I just cultured, it was HSV. More, but it could look pustular, umbilicated, or horrific. These are all patients with eczema herpeticum. Just don't miss it. For the residents out there, what's this? Red neck. Sorry, I shouldn't. I'm from Texas, so I can say it. Dermatitis. Dr. Siegfried, thank you. And this is MRSA. Okay, and then we'll just finish up. I don't need to talk too much because you're going to have our star speaker will be giving it next after our break. These are eczematous changes of the face. And so she stopped Dupy because she heard about Dupy red face on your left. And it's because, and she'd only had like 2 injections, but she had cyclosporin withdrawal. So she stopped her cyclosporin right when she started Dupy. I wanted her to continue for 2 months. And she heard 2 weeks, and then her face blew up. So she's fine now. She's totally clear. And then on the right, it happened to her again. Wasn't cyclosporin. That was, she put on gel nails. She knew she was allergic to acrylate, but she thought the gel was different. I had to look it up. Okay, so then just remember, David's going to go through this, a pragmatic approach of when you should patch test. Facial dermatitis, I think, is a reasonable reason to patch test. And you can patch test on dupilumab, as we nicely heard from Meta earlier. Okay, so in summary, just be a dermatologist. Use your morphology, history to identify the most likely causes. Don't just stop dupilumab right when you see a red face. There's a lot of confounding factors. Please consider TCS withdrawal and ask about the frequency of use and the history of use. New onset facial dermatitis is a good reason to patch test. Don't miss EH, so good job. Lots of different morphologies. Non-steroidals, I think, are best for chronic facial derm. And then consider antifungals, and please let me know if they work. So thank you so much.